Okay, welcome everybody. I'm Jennifer. I am the membership chair of the Behavioral Health Nutrition DPG, and I am also acting as a mental health resource professional temporarily as well. And today, Jean is going to chat with us. I'm sorry, Jean is our resource professional for the IDD branch of our DPG, and she is going to chat with some research that she's been doing on Down syndrome. So, Jean, I'm just going to let you, if you want to introduce yourself more, just take it away.
Okay. Hello, everybody. Thank you for coming. I don't know where you are, but it's freezing here in Maryland. Um, and I just want to give a quick disclosure. I'm not a parent of a child with Down syndrome. I don't know, some of you may be. I have no conflicts of interest related to this topic. I do have many friends who have children with Down syndrome, and I've seen how difficult it can be for these families to help their loved ones to maintain their health. So as many of you, or some of you may already know, I do have two children who fall in the autism spectrum. And that's why I know so many people who have children with Down syndrome, because my world revolves around disability. But I have never, I have no family members, and I don't have direct experience with this group. So I just want to start with very simple things. I was saying to Jennifer, when I was in school, I know it was 100 years ago, but it may be the same today. I learned nothing about Down syndrome. In fact, I don't think it was ever mentioned. So what is Down syndrome? So I'm going to talk about that, and I want to mention something very special. So today is March 21st, and it is World Down Syndrome Day. Down Syndrome Day, it's celebrated on the third month of the year on the 21st day because people with Down syndrome have an extra copy of chromosome 21. So instead of having two copies of chromosome 21, they have three. So we get to March 21st or 321. About 700 babies a year are born in the US with Down syndrome, and it's the most common genetic condition. It occurs worldwide. And 95% of children with Down syndrome have the chromosome 21 with three copies. There are two other types, and I'll briefly mention that as well. Where I live in Maryland, families are really fortunate. There's two specialty centers. One is at the
Hey,
University of
gosh.
Maryland. Are you okay? And the other is at Kennedy Krieger Institute. But there are specialty centers all around the country. And so if you do know somebody interested in working in this field, I would definitely seek out the specialty centers in your state. And if you know somebody who does have a child, or they bring a child to you, it's important for them to get the care they need. So you should be aware of the resources that are out there. Individuals with Down syndrome have multiple health challenges, and they change as they age. So it's viewed, the American Academy of Pediatrics breaks it down by stages, starting prenatally. I'm not going to go into all the stages. I'm just going to say that at every age, they have multiple health challenges, so they need to be closely followed. Individuals with Down syndrome have increased risk for celiac disease. They have an increased risk for heart disease, obesity, sleep apnea, many medical conditions. As infants, they have increased risk of cataracts, vision issues. And some parents have said, maybe their baby has a congenital heart defect and they get it corrected in birth, but that doesn't mean that they should stop seeing the cardiologist. In fact, I know of several families where they thought their baby was fine, that become an adult or an older teenager, and all of a sudden they back in have a heart problem. And in between, they lost touch with the cardiologist, didn't continue, and created some problems for them. And they feel that their child would have done better, of course, if they had had preventive care, because I know of at least two instances where adults who are being well cared for at home wound up in the hospital for extended stays because they had heart issues that were not detected soon enough because they weren't closely followed with the cardiologist after they'd had, successful heart surgery as a child. And the parents just kind of moved on and they didn't continue to see the specialist. Um, so when we work with people, we want to encourage them that they should in fact be seeing their specialist as often as they had recommended and not just say, oh, that we're fine. And so chances are, because it does occur, so the most common genetic condition in the US and around the world, chances are you will know somebody with Down syndrome, or you will have a child brought to you with Down syndrome, or an adult, and you'll work with somebody with Down syndrome sometime in your career. So I mentioned there are two other types. You can't tell the difference between each type just by seeing a person. They have to have their chromosomes evaluated, again, a specialty center. The physical features and the behaviors are exactly the same. But the other two kinds of Down syndrome is something called translocation. It's a very small percentage where there's an extra part of the chromosome, but it didn't attach to chromosome 21. It went somewhere else. And then there's another one called mosaic. And I have met some children with mosaic, and they are interesting because they have 3 copies of chromosome 21 in some of their chromosomes, but not all of them. So some have the typical 2 copies and some have 3. So for many of these children, they're mildly affected. They don't have the same, they may not have as much of a disability as a child who has all of the 3 chromosome 21s in every cell. So that is a difference. Generally, it's hard to tell that any difference between them, but if you really know these children for a long time, you'll be able to see, well, they go on to learn maybe to drive, or they go on to complete community college, whereas a child with all of their chromosomes with triplicate in every cell, that may be out of reach for them. It just depends. So I will also mention that prenatally, I believe one pregnant woman needs to have about 3 tests in order to really confirm a Down syndrome diagnosis. And they look for changes in the chromosome that would indicate that that the fetus has Down syndrome. I also want to mention just right away, there's been research to show that even the fetus of a baby, before they're even born, have higher levels of low density lipoprotein and abnormal lipids in their blood. And that's a research area. We don't really know why they do. Now, as affects us, we might be in a program where somebody comes to you with a baby who has feeding difficulties. Breastfeeding can be really difficult. Babies tend to fall asleep before they can get enough food. They really need a lot of support in some cases because of facial abnormalities. They may not be able to latch on as well. And I would say a dietitian with a lot of lactation experience or a lactation consultant would be really helpful to that mom to build their confidence and help them feed their baby. And sometimes maybe they have to do pumping, and maybe they have to do breast milk and a formula. Each case approached differently and with lots of flexibility. Moms 35 and older, I'm sure you've heard, oh, they're at greater risk to having a child with Down syndrome. But actually, while they are at greater risk, younger mothers have more children with Down syndrome because younger women have more babies. So anybody could have a baby with Down syndrome. And So if, if you work for WIC or you work with an infant and toddler program, you're more likely going to see a child with Down syndrome who is going to have feeding issues. And I would say there's a lot of information available that you can arm yourself with where you can be helpful to the mom. Because remember, they're not going to have a whole lot of time to be looking up things on the internet unless they had lots of advanced knowledge, and they may not. And if they're an older mother, they may be managing older parents, other children, working full-time, like they have a lot on their plate. So if there's anything you can do to help them, that's really going to be valuable. And as children grow and develop, a big question is, well, what growth chart should you use? Well, it's interesting. So American Academy of Pediatrics recommends using both growth charts. There is a growth chart for patients with Down syndrome, but as kids get older, children 10 years and older, you can detect obesity apparently better on the CDC growth charts and the BMI charts than you can on the Down syndrome chart. So for children, we always want to see a growth curve that follows along on the same curve, as long as it's a good curve. Like if they're at the 25th percentile on the Down syndrome chart, and they're at the 10th on the typical, and that just continues along, then the child is growing. But if you are working with either one of those charts, and both, I tend to use both, you might detect more that, oh gee, this doesn't look great, to help you identify problems sooner rather than later. But if kids are 10 years and older, it's okay to transition over to the CDC growth chart. You might still want to continue with the Down syndrome growth chart, but CDC and the American Academy of Pediatrics recommends using both, and the CDC is more beneficial looking at obesity. So I found that interesting. And I hear an echo.
Okay, I think everybody, oh wait, yeah, I think everybody's muted now. You should be good.
Okay, thank you. Anyway, some of the areas where we may also be called upon, Down syndrome individuals are prone to obesity and cardiometabolic risk factors. As I said, even the fetus has elevated lipids, thyroid conditions, celiac disease. These all require specialized knowledge for the families to provide meals to support their child with healthy growth. And so it wouldn't be unusual for them to seek out, and they should seek out, a registered dietitian or be referred to us. So I looked at a really interesting article, diet quality and cardiometabolic risk factors in adolescents with Down syndrome. It's a February 2023 JAND article, and they were looking at a group of adolescents with Downs and a matched set of controls. And if a person is at risk for obesity, that also puts them at risk, and this is true for people with Down syndrome, for diabetes. And independently, they're at risk for diabetes, high blood pressure, orthopedic issues, and they already have issues with sports and athletics due to low muscle tone. So it's really hard for some children to get enough exercise and to control for all these factors. So my own inclination is, well, I guess if they're having obesity, they're overeating or they're not eating a good diet. Some of that may be true, but what they found in this research is that the diets of the individuals with Down syndrome were generally healthier than their matched typically developing peers. Now, they were looking at the healthy eating index, which the highest score is 100. So the Down syndrome group, it's not like they were great. They scored at 52.7 points out of 100. But the typically developing peers were at 45. So adolescents in general don't have a good diet. They work hard to undo what parents tried to teach them, I'm pretty sure. But meanwhile, parents do continue to work really hard to ensure that their child is provided healthy diet and follows the dietary guidelines, which is what the Healthy Index scores it on. So we know that the Down syndrome group, and these are American kids, ate more fruit, greens, beans, dairy, and less saturated fat. Couple things, though, that stood out in this article is that they had more refined grains than their typically developing peers. Don't know why, but they did. And they had more sodium, especially the children who were more obese. Their diet was higher in sodium. In fact, the overweight and obese children with Downs had the highest intake of sodium. So that was extremely interesting because it wasn't like junk food or ice cream or things that we think of that push people's lipids up or push weight up. It was actually sodium intake that was a big flag, and refined grains. So, of course, grains, if you think of refined grains like donuts or cookies, they're all high in sodium. So that may go together. This article didn't go deep enough into that, and they acknowledged that, and it was a small group. So it's interesting work, and I don't know if it's replicatable and needs to be studied more. I do know that in adolescents with Down syndrome have a high incidence of LDL cholesterol compared to controls who are also overweight or obese. So something goes on with the trisomy 21 that increases the cardiometabolic risk, even if you take two groups of overweight kids, the one with Down syndrome will have the higher incidence of LDL and greater risk for cardiac disease than the typically developing peers. So some of the things that RDs can work on is working on helping identify if the child is overeating, getting excess sodium, why they're not getting whole grains more, and try to work within the family unit to see how they can align the diet more with dietary guidelines, focus on vegetables. Another point is that children who eat in school, they may have a higher intake of whole grains because it's required to serve whole grains, and they may have lower sodium because recently, the sodium guidelines keep going lower. So if the study was done today, you might have a different outcome. I don't know, but it is interesting to think about. And I also know that parents may worry that letting their child get lunch in school, or they may pack a lunch when maybe getting the lunch at school is okay. So the lipid markers were not correlated with diet in this research. They were related more to having the extra chromosome 21. Other things that may be affecting their higher risk is that children with Down syndrome have a higher rate of obstructive sleep apnea. And it's interesting, the American Academy of Pediatrics recommends that 4-year-olds,
Okay.
4-year-olds be screened for obstructive sleep apnea, the 4-year-olds with Down syndrome, and that they be monitored for that annually when they see their pediatrician. I'm sorry for the interruption. I have a sign on my door, don't interrupt, but I guess nobody read it. Let me see. So to me, it doesn't mean the study is irrelevant. I mean, the diet is irrelevant. We have a lot to do because this was just one study. We don't really know all the factors that affected the results. And so working with individuals with Down syndrome, we should of course encourage them to eat a healthful diet. But we shouldn't make them feel guilty if they have elevated lipids, for example, because it's beyond the diet. It's related to their condition. But I I think, there were markers, but they weren't significant enough that showed the higher intake of vegetables, higher intake of fruits, leaner proteins did show some improvement in these lipid levels, but they still weren't within normal range. I hope that makes sense. Another interesting study that's very recent, it just came out in January 2024 by the National Association of Pediatric Nurse Practitioners, looked at the management of children with autism spectrum and families of children with Down syndrome and compared the effort required to manage the child's condition and their ability to manage the child condition within the family. And it's also very interesting because as a dietitian, it's really important for us to understand the family's challenges, because if we're giving them information that they can't use because it's too difficult, we're not helping them. And what was interesting is that the families, the caregiver, mothers are the main caregivers still today. And they found the perceived effort of the families was about the same between the two groups. And also interesting, and I didn't mention this earlier, many children with Down syndrome have traits of autism. And so this is something that also should be evaluated by the pediatrician. They should be assessed for autism. So there's a whole range of things, and American Academy of Pediatrics does a good job of laying all this out. But you should be aware of it so that if you have a family and their child's not being assessed for these things, then you need to kind of check into where are they going for primary care and should they be at a specialty center. It did say that families with children with more autism spectrum behaviors had the greatest difficulty managing caregivers, but overall, the effort between the two groups was very similar. And so I just feel it's important for us to understand the stresses of the family and the caregiver as we try to develop solutions to help their family feed their child and their other children. So the child is not usually by themselves. And there's, husbands, parents, there's so many people involved. You also should be aware of social organizations and support groups in your area that can help make space for ways to make the responsibility of feeding less work. Parents are amazing support for one another, but not all communities have it and not all communities give it to each other. Culture can have a big impact. Some cultures will not reach out as much as others. Asian communities often don't reach out. They feel embarrassed and they don't get the help they need. So it's important to make them feel comfortable. Also helping them apply for services, getting social workers involved if they're not already. And a lot of states have waiting lists, and I've talked about this a lot because it bothers me. I can't believe American children have to wait on waiting lists for services they desperately need. But if your family isn't on a waiting list, you need to find out why, because they're going to need those services, and the sooner they get on the waiting list, the better off they are. Most waiting lists open at age 3. So in my case, for example, we were on a waiting list at age 3. I have twins. My daughters were on a waiting list. They did not receive services until they were 13 years old, and I was deemed to be in a medical crisis, which was breast cancer. So that's how they got services when they were 13. We might have been waiting till 18 if I hadn't gotten sick. But every state has a list just about. But when you're on that list, you do have access to more information and some nonprofit organizations, tertiary care centers, like at the time when we were on the waiting list, Kennedy Krieger looked at that list. They came out, they weren't a government agency, but they came out and provided invaluable help and expertise in how to manage my twins. And it was huge help. And there were grants that we were helped with. So it's not like we had no help. And there are programs throughout every state. So it's important if you're going to be interested in working with this population, or even if you only see it occasional, at least know how to refer them on to get them the help they need and what's available. And also always evaluate for adequacy of food and resources, know about food banks and equitable, things that can make things equitable for that family. They may be too embarrassed to tell their doctor, but we are often able to find things out about what they had available in the home because we're doing a 24-hour recall. I also want to mention many articles in our journal were really old, from 1990s, 1980s, even later, and there weren't many recent articles on Down syndrome and nutrition. So I personally am not a researcher, but if you are, or you're young and you're interested in research, this is an area that if you have a passion about, we need more people to do work in this area. We don't know that much. And anecdotally, I know that my friends who take their children to dietitians do get frustrated. They feel the dietitians often don't understand, they stop going. And and that's a shame. So we want to be a resource that is a positive resource in their lives. And I hope I talked enough. I'm going to stop. Does anybody have any questions?